Okay, go ahead.
Hi guys, my name is Katie. I am an RN MSN student with Gonzaga University. For my practicum last semester, I was helping out with Christy doing some stuff with pediatric nursing here at the hospital. And when I went through the floors, the ICU and med floor specifically had asked for education on pediatric IVs, which I did yesterday, and then also some education on enteral feedings. So that's what this presentation is going to be about today. A little bit of my background: I graduated with my ADN from Western in 2011 and moved up to Spokane, Washington. I was there for 4 years and worked for 4 years in private duty pediatrics. 2 of those 4 years I was on the medical floor at Sacred Heart Children's Hospital, and then the other 2 years I did pediatric hospice. So the majority of my experience has been pediatrics. Currently I'm working in Green River at Best Home Health. I'm the nurse supervisor for the Green River office. And then we're also starting up hospice. So I'm the nursing care coordinator for Sweetwater County for hospice for Best Home Health. So this will be the presentation. At the end, there'll be time for questions or if you have anything that you guys want to discuss. Thanks. So the very first thing, what is an enteral feeding? Kind of base, but it's the introduction of nutrients and fluids into a functioning GI system when oral intake is contraindicated. There are several different types of devices that you can use. Generally, for the short term, it's going to be an orogastric tube, which is going to be inserted through the mouth down into the stomach, the nasogastric tube, which goes through the nose down into the stomach, or the nasojejunal tube, which is going to be inserted through the nose, past the jejunal sphincter and into the small bowel. And the little picture right there kind of shows the tract of where it would go and where it would stop for each of the different tubes. For more long-term feeding tubes, you have the PEG tube, which is a percutaneous endoscopic gastrostomy tube, which is inserted directly into the stomach through a small incision in the skin and then through the abdominal wall. There's the G tube, which is what I see most often, which is a Mickey or a Mini. It's similar to the PEG tube, but it's a low-profile device that's held in place with a balloon, very similar to a catheter. The J tube, the jejunostomy tube, is inserted directly into the jejunum through the incision. And then you also have a GJ tube, which is a triple lumen feeding tube that's inserted into the stomach and then passed through the gastric jejunal, the sphincter into the jejunum. So these are pictures of the last 3. On the top with the blue, you have a PEG tube. So those will see a lot of times I see PEG tubes that are placed before they'll put in the actual Mickey button. So it's kind of when the stoma is still new. The bottom one is the G tube. You have a Mini and a Mickey. Really the only difference between those two is going to be the extension and the way that they lock in. Otherwise they are very, very similar. And then the GJ tube is over farther on the side. It has the triple lumen, the balloon port so that you can secure it, the port that goes into the jejunum, and then also the port that goes into the stomach. Really quickly, because my links don't work here at the hospital, I have some videos. The first one is just going to be on inserting an NG tube. Probably it's not going to be a preterm infant at this hospital, but I thought it was still a pretty good video. It just goes through some of the indications, contraindications, checking placement, different things like that.
Objectives of this module are to know the indications and contraindications for a feeding tube, potential complications to look for during and after placement, and to learn how to place a nasogastric or orogastric tube. A gastric tube is a single lumen synthetic tube that is passed from either the nose, a nasogastric tube, or the mouth, orogastric tube, into the stomach. It is incrementally marked in centimeters and is radio-opaque UC visualization during radiography. Indications for a nasogastric or orogastric tube may include infants who are unable to take milk by the oral route due to prematurity, feeding immaturity, or neurological disease with poor oral motor skills, infants who have respiratory distress with tachypnea, or those who require assisted ventilation. Once placed, the gastric tube can be used to provide enteral feeding or medication and for checking the stomach contents for either pH or volume and content of gastric residuals. The nasogastric or orogastric tube can be used for venting or gravity drainage of the stomach. Special double-lumen gastric tubes with multiple distal side holes attached to intermittent or continuous wall suction can be used for decompressing the stomach in cases of anatomical or functional gastrointestinal obstruction. Contraindications in nasal or orogastric feeding may include congenital abnormalities such as esophageal atresia, where the proximal esophagus ends as a blind pouch, or esophageal perforation. Complications of the procedure may include apnea, bradycardia, or desaturation, irritation of the nasal mucosa, perforation of the pharyngeal, esophageal, or gastric mucosa, displacement due to loss of adhesiveness of tape due to secretions or the infant pulling out their own tube, and increased gastroesophageal reflux. The infant is monitored throughout the procedure for respiratory distress or bradycardia. You should not push against any resistance, and you should stop the procedure anytime if there is coughing, gagging, apnea, bradycardia, respiratory distress, or cyanosis. Placement can be confirmed by a combination of measures, which may include aspirating stomach contents, the presence of acidic pH of less than 5 in the stomach, assuming that the infant is not being treated with antacids, auscultating over the stomach while injecting 1 ml of air into the stomach with a syringe, or abdominal X-ray. Your feeding tube is now ready for use. The following section outlines the equipment currently being used at one of our NICUs to place a nasogastric or orogastric tube in a preterm infant. You should follow your own institution's guidelines. You will need the following pieces of equipment.
Sterile field. It's not sterile, it's just a clean procedure. Take it on to secure the tube. We're looking for the tube. A little water soluble. We're going to use a French feeding tube. This baby. Use a syringe to check for air placement once the tube is in. So attach a 3 cc syringe to the end of your tube. And trim your tiger arm as you would need to secure the tube. Generally about 1 to 2 centimeters wide. Usually more than enough to hold it in place. Alright, so we're going to put a new orogastric tube in our little friend here. He pulled his out. So there are 3 methods. We're going to use a 6 French. There are 3 methods to measure. One is the nose to the earlobe to the xiphoid process, nose to earlobe to umbilicus, and nose to earlobe to the midpoint process between xiphoid and umbilicus. We're going to be using the 3rd measurement, which is the edge of the nose. He's going to try to help me. To the earlobe, which for him is 6. There you go. It's the midpoint between the xiphoid and the umbilicus. So the xiphoid on him is 15. The umbilicus is 21, so we're going to go to 18. So when you're placing the tube, it's much easier if you're not fighting the infant and you wait for them to open their mouth a little. You're going to slide it in above the tongue, across the palate to the oropharynx. It should go down very easily into the esophagus. You should not be any resistance. If you get resistance, stop and start over. This is going down very easily, and we are at 18 at the lip. Tubes can be secured in a variety of ways. We tend to use Duoderm on the chin to protect the skin, and then we use Tegaderm over to secure it in place. You want to double check your measurement before you put your Tegaderm on, so we're 18 at the lip, 9 belly, and we're going to secure the tube. Doesn't seem to be too bothered by this. Just trying to help him. Once your tube is in place, you want to try to aspirate some gastric contents. Your baby's on CPAP, or non-invasive ventilation, you will get quite a bit of air out of the stomach. In this one, you can see the gastric contents coming out through the tube. You can check placement in a couple of ways. The way that we use is auscultation. It can also be checked with pH. pH, you want to be careful using any kind of pH tube water to put on top of the because it will alter your pH. So we're going to inject 2 cc's of air into the stomach and listen for placement. You hear a pretty loud bubbling. This tube is in place. So now it's ready to be used.
So the next one is just it's a 2-minute video. It's very quick, just on placement of the Mickey mini button. Like I said before, it's very, very easy. It's a lot like a suprapubic catheter as far as the balloon. They'll be marked with the French and then how long they are in centimeters. And then they should also let you know what the size of the balloon is. Normally I've seen 5 milliliters. Most of the time it's a full balloon, but you should always check the doctor's order because it'll be in there as well with how full the balloon is going to be. It's not always going to be filled with 5. It doesn't need to be sterile water, and again, it's not a sterile procedure because it's going into the gastric. But if it's a kiddo that has any immunocompromisation or anything, I always use like bottled water for them just so it's clean. So you can see the kit up there on the bedside table. It does come in a kit, and they have everything that you'll need to change it, including a new extension. There's the little port right there where they're going to just pull out the water to deflate the balloon. And then it should just slide right out. Have a gauze ready for a little bit of the gastric contents that'll come up. And then it should just slide back in. Some kits actually have a little threader because it is pretty soft, the material, when you're putting the stem in. So they'll have a threader to keep it from bending if it's a newer stoma to get it to go through. And then you just refill it, and it is secured. And then the rest of that video, they're just putting the split gauze around it to protect it if there's any leaking. Sometimes a little bit of leaking is normal from the G-tube buttons, but it shouldn't be so much that it's causing damage to the skin. Normally the standard is every 3 months unless there's a malfunction with the button. Then you can change it more often. And then most of the time we recommend at home or probably in the hospital that the parents are going to have an extra one just in case it gets pulled. If it gets pulled, you can just, clean that one off and put it back in as long as it's still functioning. A lot of times if the kiddo pulls it out themselves, it still has a full balloon, and it can rupture the balloon when they pull it out, which is also very painful, as I'm sure you would imagine with a 5 mil balloon. Yeah. But I've see kids do it all the time. Or if the tube gets caught on something and someone's not paying attention when they're transferring them and pulls it out, it can rupture the balloon. As far as formulas, so infant formulas that are intended for bottle feeding or enteral feeding are the only ones that are regulated by the FDA. Other types of formula are considered medical foods and they're not regulated, so it doesn't have to be labeled as a medication would be or as the infant ones. So it's really important when you're mixing or doing a formula to just pay attention to what's on the label and making sure that it's the correct kilocalories, the correct supplements added to it, because they're not universally labeled because they're not regulated. They come in powdered, liquid, pre-mixed forms, and then human breast milk can also be considered an enteral formula. The liquid formulas are pasteurized, and those are the preferable ones to use. Powdered formulas are not, and they can be contaminated because they are made in like an open factory, and again, they're not regulated. There have been cases of infant death and small child death from bacterial contamination in hospitals from powdered formulas, and just when clean preparation technique isn't used. So even though it's not a sterile thing, it's still important to remember to keep it as clean as possible, because anything you're introducing, you're going to introduce into that person's body. Some different things on hang time. So for clarification, a closed system is going to be like where it's the big bottle of premixed formula. You don't open the container other than to spike it. It doesn't have a bag. It has the sterile tubing that then just connects in, and it's one-time use. You throw it after it's ran through. An open system is what you see more commonly. It's the bag. It's not sterile. You pour the formula in and attach the extension. So for sterile formula in an open system for an infant, or non-sterile powdered formula, or non-sterile additives and human breast milk, the hang time is only 4 hours. So you can't put more than will run through in 4 hours. For a sterile formula in an open system, so that's one that's pre-mixed that you're just pouring into the bag, the hang time is 8 hours. Sterile formula in an open system at home, best practice is 12 hours. And then for a sterile formula in a closed system, can hang for 24. It is considered a medication as far as nursing considerations go, and so you do have to have a physician order for an enteral feed. It's got to contain the patient's name, date of birth, a current weight, especially on pediatric patients. It is of utmost importance that you're getting a daily weight on them. Especially in the really little kiddos and infants. Having a weight that's off by a couple grams can be a really big deal, especially when calculating the calorie needs. So it's very, very, very important that you have an accurate daily weight. They need to have the specific formula, any additives that are going to be added, and those dosages, the route and the access site, whether you're doing gravity, continuous, bolus feed, the rate, and then if you're going to be advancing or transitioning. It's also important to keep in mind any other additional orders. If they have some sort of a fluid restriction, you need to factor in the maintenance flushing and flushing between medications with that fluid restriction. Yeah. Some of the nursing considerations, the feeding bags have to be labeled. It's just like a medication or an IV bag. They need to be labeled with the initials of the person who put them up, what formula's in it, what time it was put up, the date, and then any of the additives that are in the bag. It's always really important to check the bag, the tube, the extension, and even the container of the formula. I've seen them come curdled actually in the can that you get them from, where it's like past an expiration date. So it's important to check. A lot of people don't always change the extensions. The extensions are another part of your tubing. They can get very disgusting. They have to be changed with each bag. The hang limits extend to the extension as well. Vomiting, nausea, diarrhea are pretty common complications. One thing that I found that's helpful is to think about PO consumption in the age and the size of the kiddo that you're using, or that you're running the enteral feed on. So if you have a 4-year-old, you're not going to be able to bolus 20 ounces of fluid without them puking. Could a normal 4-year-old chug a 20-ounce glass of something? Probably not. And so it's just something to keep in mind. A lot of times I actually don't see bolus on the really little kiddos. it's very unusual for those actually on very little kiddos. Aspiration is always a constant threat. You don't need an order for common sense. The head of the bed always needs to be elevated during and after, or they need to be, if not in the head of bed, in mom's arms, on a pillow, something. They have to be bolstered up. Very, very easy for reflux and aspiration, especially in kiddos. And then very important to always check the placement of the tube before you administer anything, either with the air bubble or pH strips. Again, with the pH strips, make sure that you're thinking about what medications you're using, because any of the proton pump inhibitors or H2 blockers are going to alter the pH in the stomach, so you're not going to get accurate results on the strips. Human breast milk should not be any more than 48 hours old if it is fresh, and then it does have policies on how it should be stored. If possible, again, because of possible contamination, use liquid additives rather than powder. Just like with an IV, you want to scrub the hub, even though it's going into the stomach. You don't want your connectors dragging on the floor, not being clean. It's gross. Enteral feeding connectors, this is a recent change. Most of them are going to be purple, and they're a little bit larger, and that is to keep from misconnecting. There have been instances where enteral feeds have been hooked up to IVs and ran into the veins rather than into the stomach, and so they are changing the connectors so that that's not even a possibility anymore. It's only become like a thing where the manufacturers are in the last 5 years. So remember that the gastric contents are caustics. Some leaking is normal, but you need to protect the stoma and the surrounding skin, and care needs to be performed at least once a shift, where you're assessing it and looking at the stoma site. Even if there's just a little bit of water out of the balloon, it can cause leaking. A lot of kiddos that are at home or who have had long-term, they actually have what they call button buddies. They're little flannel button things that just go around their feeding tube instead of using the split gauze, and then they're reusable. Mom or dad can just wash them. They also have button protectors that it looks like an ACE bandage for the really little kids that goes over it and kind of holds it down, even though it's low profile, closer to the skin, so that it's not getting caught on things and so that the kiddo can't grab it and pull it out. So if you don't have one of those, you can always use an ACE bandage, just loosely wrapped, not for compression, but just to go over the feeding tube. And then always protect the tube. Like I said, dislodgement can be very painful, especially if it's pulled out with a full balloon. It does happen. It's not something to panic over. If you don't have an extra tube handy, a lot of the tubes that I see are 14 French. You can actually even just put a Foley in to keep the stoma open until you can get a new feeding tube. And that is the end. Those are just the references. Are there any questions?
Are you here at the hospital?
No, I actually, right now I'm working over at Best Home Health in Green River. I'm working on my MSN right now through Gonzaga. And so for my practicum last semester, I was working with Christy on improving pediatric care in the hospital. And enteral feeding was something that the nurses had requested an education module on.
I know when those leaky tubes come out, if you don't get a Foley in there within half an hour, they seal up very quickly.
Yeah, the stoma do close very quickly.
You've got to call the doc right away, because if you wait a half an hour, they'll close.
Yep, absolutely, and that's part of the reason at home, here you probably already have them, we always have the parents have an extra kit. They always have an emergency kit, so that they have an extra tube, an extra extension, all of the stuff that they would need to put in a new one. And they're supposed to carry that with them everywhere they go, so the kiddos that go to school take it with them to school in their backpack.
The kids that get fed at school, do they change the tubing every time too?
So most of the time in Green River, in the bigger areas in Spokane, the school nurse would come in and do the tubing and change it. The extension doesn't necessarily at home need to be a brand new extension. We wash them with soap and water, and then with a 1-to-1 vinegar would clean them to reuse at home. In the hospital, you'd probably want a new one. But they would just have the nurse run them. At the schools in Green River, they actually, since they don't have a nurse at each of the schools, they will not run the feeds at school. So we have to adjust the feeding rates for when they're at home to make up for that time that they have to be off the feed at school.
How many kids do you have over there now?
In Green River, right now on home health services, we have 6, and 5 of the 6 have feeding tubes. One is a GJ, and all of the others are Mickey's buttons. And I think there's 2 or 3 kids in Rock Springs that are on services with them.
The gastrostomy tube, that comes out, what do you advise the parents there to do? Do you teach them how to put it in, or do they come to the ER to have it put in, or what?
For which tube?
Or if you have an oral gastric tube or nasogastric tube?
Nope, so the ones for them, when they are sent home, if they have home health services, they just call the nurse.
Okay.
The one kiddo that we had pre-me, he was born at 21 and a half weeks. He was very, very early. That came home with it, mom, before they would discharge from primaries, mom had to be competent with putting it in. She didn't like doing it, but she could do it in an emergency. Normally, they just call home health, though. We have those kiddos on services.
24/7?
Mhm,
Home health?
Yeah, we have an on-call, 24/7 on-call, a nurse.
Yeah, there's always a worry. The parent puts it in at home, if they go down and get a trachea, and
Yeah.
then they get aspiration pneumonia.
Yeah, we always very much stress with them that they still need to check for the gastric contents, and if they have any questions, concerns, problems, that they need to call the nurse. Usually we just have them call us to have us do it. They have to be comfortable with it in order to be discharged, but they don't usually replace them themselves.
Well, thank you.
Yeah, absolutely.
Thank you, Katie.
Do you see gravity a lot when we're feeding that little one?
No. Most of the kiddos are on pumps. They very, very rarely do they do a gravity or a bolus feed on a kiddo that I've seen.
Just waiting for it to finish.
Yeah, usually we have them on a pump. Some of the kiddos, depending on how they have them run, some of them are on continuous feeds. Those kiddos are usually like our spastic quadriplegic CP, so they're not up and running around anyway. The kiddos that are more mobile and can do it, we try to do a more normal schedule. If they can tolerate it, that they get most of their feed at a little higher rate, do one at breakfast, one at lunch, one at dinner, so they're not continuously hooked up. If they do have to be continuously hooked up, they have little backpacks that you can put the pump in, and then we just try and shorten the tube with like a bread tie, so it's not quite so much, and just shorten things up a little bit and put it in their backpack. And then they can run, play, do whatever they want to do. And then just put the ace bandage around so they don't pull it out while they're hopping and jumping. Yeah.
All right, thank you, Katie.